Hi, everyone. Thanks for joining us tonight. We appreciate you taking the time out of your evening to come learn more about your options for colon issues. And our presentation with Dr. Das will hopefully be informative for you. Sorry. Just want to do a quick housekeeping before we get started. First, I want to remind you that your lines have been muted. So if you have any questions, please feel free to put them into the Q&A box or the chat. Also, you should see a poll on your screen as you're joining. Please, if you wouldn't mind completing the poll before we get started. My name is Natalie Quirk, and I work with Medtronic. And tonight, I have the pleasure of hosting this webinar with Dr. Das, where you'll get to hear from her. Dr. Das is a colorectal surgeon with Florida Surgical Specialists. She provides experience and compassionate care that you can expect from a top-notch physician. She offers a full range of services and procedures with a special interest in colorectal health. Dr. Das has a special interest in treatments for fecal incontinence and looks forward to discussing this more in detail tonight. And as a reminder, again, just one more time, if you have any questions, please feel free to put them into the Q&A box at the bottom of your screen. Without further ado, welcome Dr. Das.
Hi, everybody. So as Natalie said, my name is Dr. Das. I am a colorectal surgeon that practices out of Sarasota and Bradenton, Florida. And I've been in practice for about 6 years now. I did my training, most of my medical training was in Pennsylvania. So I went to Penn State University, the Hershey Medical Center for medical school, followed by my surgery residency was done just outside Philadelphia in Abington Hospital, which is now a Jefferson affiliate. And then I came down to Florida, did my colorectal surgery training in Orlando Health, and then landed here in Sarasota, Florida. So over the past 6 years, I have seen about over 400 patients in my practice alone with fecal incontinence. And that alone should tell you just how big of a problem this is. It's definitely a topic that most people do not want to talk about. And, knowing is half the battle. So if people aren't talking about it, they don't know that there's a solution out there. So it's certainly become one of my passions to share the knowledge that I have about this topic with people. And just knowing that there is a simple and effective solution out there, I think it's become my prerogative to really share that with people and reach anybody that wants help and help them get it. So moving on, a lot of people have the thought, when they have issues with incontinence, it really affects their daily lives a lot. So it keeps people from going out. People stop doing things that they love to do. They stop wanting to go out to dinner with their friends or go out on the golf course, or, how can I go on a date if I have incontinence and have to worry about, having an accident while we're being intimate or something like that. It's very overwhelming. And even when people go to the doctor, they don't feel, either they feel too embarrassed to share that knowledge or share that concern with their physician, or if they do actually, work up the courage to say something, a lot of physicians aren't aware of the treatments that are available. And so they just don't feel heard. And that's something that I hear from a lot of my patients, is I just have felt ignored or neglected or just not heard, or people made me feel like I was crazy for having this issue. So, it says 54% of people with fecal incontinence have not discussed it with a doctor. I mean, I think that's even a gross underestimation, and it's definitely time that changes. It's important for everyone to know that you're not alone in this. Both fecal and urinary incontinence are issues that we see across the board. It's not just a disease of old age. It can affect young people. It can affect old people. It can affect men and women. It's very common in, women post-pregnancy. It's common in people who have suffered from chronic constipation their whole life. It's more prevalent in people that have Alzheimer's disease or dementia, or asthma. I mean, these are things that anybody can suffer from. So it's embarrassing to talk about. It, you know, it leads to a lower quality of life, but it's important to know that it's common, and at least 1 in 12 people are affected by fecal incontinence, and not nearly that number is talking about it. That's 21 million people across the United States, and we treat less than 10% of that. So, you know, what is the natural progression? A lot of people attribute this to, you know what, I'm getting older and this is just the way things are. You know, I hear from a lot of people that, you know, they come to me after 20 or 30 years of suffering from incontinence. And as soon as they find out that there is a treatment for it and they go through the treatment and it works, they're shocked, they're surprised, they, you know, they're actually, there's tears when they say, I wish I had, you know, heard about this or known about this 15, 20 years ago. And I think a big part of that is it's been normalized. You know, you hear about your mother or your grandmother or your grandfather that suffered from these issues, and people just dealt with it. They deal with it by, you know, taking medications. I don't know how many people I have that just buy Imodium because that's the only, by constipating themselves, that's the only way they can treat their issues, or they just live in diapers, or they change their whole wardrobe because of these issues. And none of that is normal. So, you know, if you're the type of person who knows where every bathroom is around every restaurant or every store that you ever go to, that's not normal, and that's not a good way to live. So there is a solution for that, and your body is trying to tell you something. So how do our bowels work? Well, we have nerves that stimulate the sphincter muscles that control your bowels and your bladder. The nerves are located in your lower back, and over time, they can weaken, the stimulation can decrease. There's different ways to treat the problem, but mainly it's retraining those nerves and those muscles to work together and coordinate and help regain that control that you've lost over time for whatever reason. So the good news, there are treatments, different types of treatments available, and we're going to talk about those things today. They range from conservative treatments, such as something as simple as doing pelvic floor exercises, Kegel exercises on your own, physical therapy, all the way up to surgical treatments. And so we'll talk about those more in detail. So conservative treatments, I mentioned dietary modification. So one thing that people tend to do, especially with fecal incontinence, is they kind of purposefully try to constipate themselves. So taking in fiber can help to bulk up your stools, but also taking medications like Imodium or Lamodal, that's often what people resort to in order to try to decrease the frequency of their bowel movements. In reality, though, that's not a great solution long term, because even though it might, you know, buy you some time to get you to go to the bathroom, you know, you're basically binding yourself up, and you're not going to be able to go and pass that stool when you need to. So that's kind of a temporary solution. Physical therapy. So there are pelvic floor physical therapists. They're specially trained individuals that can help you retrain those pelvic floor muscles. This is a great option, especially for older patients, or actually even younger patients, because younger patients often have even better success with this. When you have good muscles and it's just a matter of retraining the nerves to coordinate with those muscles, a lot of people have great responses with biofeedback and pelvic floor physical therapy. And we kind of already mentioned the medications to kind of create constipation. So when somebody has tried those things and they've kind of either failed or gotten a partial response and are looking for something more, that's when Medtronic Interstim therapy comes in. And what this is a device that it's a stimulator for your sacral nerve. So it's called a sacral nerve stimulator. And I like to describe this to patients as a pacemaker for your rectum or your bladder. So what it is it's a small implantable device. It gets implanted in your lower back, and it has a small electrode that stimulates the nerves that control your bowels and your bladder. And it basically helps to provide stimulation that you've lost over time. So you regain that control and tighten up those muscles that you kind of can't do on your own. A lot of people ask, is this something that I have to turn on and off? Like, do I have to be able to turn it off every time I have to go to the bathroom? No, that's not how it works. It's something that is actually on at a very low threshold or low stimulation all the time. And the idea is that it mimics kind of your natural body. So it gets you back to where you used to be when you did have good control over your bowel movements. This is the best and most effective treatment that's out there for incontinence currently. It is over 90% effective for the treatment of both fecal and urinary incontinence. There are some other treatments that are available as well, such as injection of bulking agents around the anal sphincter muscle. And that is also something that certainly can be used, but it's not quite as effective, or it has not been proven to be quite as effective as sacral neuromodulation therapy. So there used to be surgical options, other surgical options, and there still are surgical options that are done today, such as repair of the actual muscles. So a lot of times fecal incontinence was seen to occur in females after a vaginal delivery, a traumatic birth, where they tore the muscles during the delivery of their rectum. It's actually been shown that unless there's a really, really big tear, meaning greater than like a 60-degree angle of the defect, that sacral neuromodulation therapy still works better than surgical repair of those muscles for most people. So it's still done, but most surgeons these days, I would say, have transitioned to using sacral neuromodulation therapy over surgical repair of those muscles for this issue. A colostomy, I don't know if a lot of you know what a colostomy is. It's a bag that you wear on your abdomen in order to have bowel movements. So basically you divert the stool away from the rectum, and the stool would come out of a bag on your abdomen. That's really a last resort for most people. There are certain individuals that it may work well for. If they are immobile, if they're wheelchair bound, it may be easier for them to empty their stool that way. But lifestyle wise, most people prefer not to have that. And so that's really used as a last resort. So Interstim therapy, like I was talking about, it's a very minimally invasive treatment. The procedure is done in 2 stages. It starts out with a 1-week trial, and the trial is usually done in an outpatient setting, either in an office or a surgery center. Now, I do my trials in the office, usually just under local anesthetic, so just a needle and some numbing medicine. And you don't even actually need a ride home that day. I mean, you could drive yourself because you're not really going under anesthesia. It's just a 20-minute procedure in the office. And so what happens during that trial is we place kind of an external device similar to what the implant would do. And for 1 week, the patient gets to try out what the device would be like. And it's almost immediate results. So you'll know almost right away if this is working for you or not. Patients are asked to keep a bowel and bladder diary for that week and keep track of their symptoms, the number of accidents they're having, frequency, urgency, things like that. And most people will notice at least a 50% improvement in their symptoms if they qualify for this treatment. And then at the end of the week, they come back to the office. We take the external device out and go over the bowel and bladder diary results. And as long as they have had good results, then we move forward with the implant. The implant is usually just a skin incision. It's done at a surgery center or an outpatient setting. And that is a surgical procedure, but patients get to go home the same day. So it's a very minimally invasive procedure. Most people have very minimal pain from it. They don't require any pain medicine other than Tylenol or ibuprofen. And you're really back to normal activities within like 2 weeks. The only restrictions are you can't go in a swimming pool, like a hot tub or pool or the ocean for 2 weeks. And you have to kind of limit your bending and twisting and heavy lifting for 2 weeks. Beyond that, people are back to their normal activities basically the next day. So, the goal here is just to take back control of your own life. Over 375,000 people in the world have had this therapy. The technology has been around for about 25 years now. So it is well researched, and really our biggest hurdle now is just getting the information out there. We need to spread the knowledge and make sure that both doctors and patients are aware that this technology is there and that it's not something you just have to live with. One big advantage of these. Hi, Eric.
Sorry.
So one big advantage of these systems, these sacral neuromodulation systems, is the technology has improved such that they are full body MRI compatible. So some of the previous devices, if patients got implants, they weren't able to get MRIs, and that was very limiting to, if they had other issues, like if they had back problems or, orthopedic problems, and if they needed to get frequent MRIs, then that was a real limitation for them. But the technology has improved greatly in the last few years, and Medtronic Interstim in particular has developed a technology called SureScan technology, where their devices qualify patients to get MRIs without having to really check anything beforehand. So this is really streamlined the whole process for both doctors and patients. So, I just want to encourage everybody, if this presentation speaks to you, if you have any of these symptoms, if you know friends or family that have these symptoms, really encourage them to reach out and find a physician, hopefully me, but any physician that can address this problem for them, because, this therapy it's life-changing. And that's one of the biggest things that I hear from people. And it's very gratifying to help somebody in that way. As I mentioned before, about 90% of people that have been using this technology see a significant improvement in both quality of life and all of their symptoms. So at this point, I will take questions.
Great. Oops, great. Thank you, Dr. Doss. We have a few questions starting to come in. So the first question we have is, what's the cost of the device?
So this device is, it is costly, but it is not costly to you. I'll put it that way. So I would say most patients that I see with a need for this device tend to be Medicare patients, but really any commercial insurance as well as Medicare generally pays for this device. We go through a rigorous process to make sure that anybody that we are putting an implant in actually qualifies for the device. So there are certain, criteria you have to meet, like you have to have tried conservative therapies such as Kegel exercises or changing your diet or, taking medications or doing those sorts of things before jumping to a surgery. But in most of the cases, and by the time patients have come into my office with this problem, I would say the vast majority of people have already tried those things. So the answer is, most insurances cover this 100%.
Great, thank you so much. The next question is, I don't have diarrhea, but I do have some underwear smearing. Would I be a candidate for this procedure?
So absolutely, yes. Not every person that has fecal incontinence has to be having full accidents, full-blown accidents every time they go to the bathroom or, can't make it to the bathroom. A little bit of smearing, a little bit of staining in the underwear. And as I mentioned, this also works for urinary incontinence. So like a little bit of leaking of urine, all of those things could potentially qualify you for this device. So, again, I would just encourage you to make an appointment with me or any physician and hopefully get you the appropriate workup done.
Great, thank you. We have a lot of great questions coming in. The next one being, could the Interstim system help with urgency as well?
Yes, absolutely. So a lot of comments that I get from patients are that they used to not be able to feel when they needed to go to the bathroom, and their sensation or the feeling of the need to go to the bathroom even improves after implantation of this device. So yes, it's not just for accidents. Like I said, it is for urgency and frequency as well.
Great, thank you. The next question is, how long does it take to get back to driving after the procedure?
So the only day that you can't drive is the day that you have the surgery done. Basically, like I said, this is a procedure that I don't even prescribe pain medicine for. Most people end up taking just some Tylenol or ibuprofen afterwards for incisional pain. So as long as you are comfortable and pain-free, you can go back to driving the next day.
And can you describe where they place the implant?
Yes. So the implant is placed kind of on your lower back. I would say kind of like around your hip area. It's very discreet, meaning, I've implanted this device in some young women and some very attractive older women, and they worry about, if I wear a bikini, are people going to be able to see this? And really, the incision is hidden to the point where you could wear a bikini and nobody would ever know that you had surgery or had something there.
The next question is, let's see. I have a bladder sling, or I've had a bladder sling for over 20 years. Would this device be a problem if you have back issues also?
So I'll take that question in two parts. So with relation to the bladder sling, this device is approved to work for urge urinary incontinence, but not stress urinary incontinence. So I would certainly recommend that you follow up with a urologist or a urogynecologist to kind of determine what type of urinary incontinence you have and whether you are qualified for this device. But that being said, a bladder sling is not a contraindication to getting this procedure done. They can work in conjunction with each other. And then what was the second part of the question? The back pain?
Yeah, if you have back pain as well.
Yeah,
Yes.
so I actually have a lot of patients who have had like hardware placed in their back. They've had spinal fusions and things like that. And that is also not a contraindication to having this device placed. Usually it doesn't interfere at all with that.
Great, thank you. The next question is, I just started ZynPep and it appears to be helping. Do you recommend enzymes as well?
Yeah, so everybody's reason for incontinence is going to be different. And that's why it's so important to have a good workup done by your physician. If ZynPep is working for you, then that means that the reason for your incontinence was something different, right? It's not muscle weakness. It's probably that some deficiency in your diet or reaction to the foods that you were eating that is now improved on ZynPep. So it's very important that people are having basically formed bowel movements when they have this device placed. So, you know, any sort of like IBS, irritable bowel syndrome, any sort of like dietary issues like that need to be addressed. Any other causes for diarrhea basically need to be addressed before we determine that it's the muscle weakness that's causing your problem.
Great, thank you. The next question is, what is considered excessive fecal incontinence? Is it once a week, 3 times a week, every once in a while? Could you clarify?
So really, you know, anything qualifies. I would say in order for the trial for this device to be successful, we would want to see some sort of symptoms happening within that 1 or 2 week period. So the longest I've ever done a trial is for a 2-week period. So we need to see some sort of symptoms within that time period. Most people are having symptoms on a daily or weekly basis, but everybody's different. There's a wide range of symptoms.
This next question is, I have a full bowel, but I can also have watery stool or pudding-like stool, which happens after a day or 2 of constipation. And he never knows, or this person never knows when it will happen. Is this something that could help this person? Or what are the steps maybe to seeing you to get more information?
Great. So, you know, it's hard to say just based on those symptoms alone whether Interstim is the correct answer for you, but it certainly does sound like pelvic floor issues could be the reason for those symptoms. So a lot of times different pelvic floor problems go hand in hand with incontinence, such as prolapses. So rectal prolapse, vaginal prolapse, uterine prolapse, bladder prolapse. All of those things can also tie into those muscles being weak down there. So, you know, we kind of just have to determine which of those problems is going on before deciding if the device would be the right answer for it.
Perfect. And I feel like that's a good time to remind everyone that this is an anonymous webinar. So some of your experiences, I think, would be best assessed by scheduling an appointment with Dr. Das. We love the questions, so keep them coming in. But there's only so much that she can answer via Zoom. So we'll try to get all of your questions answered to the best of our abilities. But some of these might need a little bit more time with Dr. Das. And speaking of, the next question is a great one. If the device stops working, can it be taken out?
Yes, absolutely. That's obviously something we don't like doing frequently. So to the best of our abilities, if the trial worked for somebody, then there's probably a reason why the device isn't working. And we always kind of test that thoroughly first. So when the device is implanted, there's several different programs that we can go through to like stimulate different parts of the nerve to see what gives you the best response. And so if once we've done all that troubleshooting and the device still isn't working for you, then yes, it can be taken out and it would be done in a similar outpatient setting, like an outpatient procedure.
Okay, great. And then this next question is, I've had severe trauma to my colon with 3 surgeries and ileostomy for 2 months. Could that be the cause to my incontinence? If that happened 17 years ago?
It certainly can be. So any type of rectal or bowel surgeries can certainly, you know, cause you to have incontinence issues. Again, whether or not Interstim is the right device for you, we would need to work you up further in the office before we decided that.
Could this device make your bowel control issues worse?
I have very, very rarely, if I don't think I've ever really seen that. You know, again, because the advantage of doing the trial is that you'll know almost right away what the device is going to be able to do for you, and the device should mimic the trial results. So if you start to have worse symptoms during the trial period, we would never, you know, put the implant in. That being said, I've never really seen that during any of my trials or implants.
Great, thank you. The next question is that I have bowel control issues likely tied to the fact that I had a stroke. And I also have some nerve damage that attributes. Could I be a candidate?
Yeah, so one of the kind of it may be considered an off-label indication because there are if somebody has had prior nerve damage, then it's something that Medicare may or may not cover this device for, but we have to, again, do further workup. I'll give you an example. There are patients that I have that have had prostate cancer and have had radiation to the pelvis. And that's one of those things where, it may not be fully studied in that setting, but I've seen it work a lot of the time. So again, the only way to really know is to do the trial and then see if it works for you. And if it does, then we have all the evidence that we need to do the implant.
Great. The next question is, does Medtronic's device help with regulating bowels? Because I can have both loose stools and also constipation.
That has not really been studied. So I will say it probably may be a future indication, but at this time, it hasn't really been studied for, the treatment of IBS or constipation.
Great, thank you. This is a great question. I have chronic back pain and I'm waiting to get an implant that will help with blocking pain messages to the brain. Would I also be able to get an implant for incontinence?
Yes, and I've actually had that situation come up multiple times. So I have had patients that have a pain stimulator in their back already. And because this implant stimulates the nerve at a different level, you can actually have two implants, both located in the back. Usually what we do is we'll put the actual battery part of it on the opposite side of where the pain stimulator is. But they don't interfere with one another.
Perfect. The next question is looking for maybe clarification on a previous question. If someone has IBS, are they automatically not a candidate for the implant?
No, not at all. It's not that they are not a candidate. What I would recommend though is that we try to get better control of their IBS symptoms before we proceed with an implant. Because what you don't want to happen is, if somebody has IBS and that's the reason they're having intermittent diarrhea, if you put an implant in to fix the muscles or the nerves, that's not going to solve their problem. So it does not make you not a candidate, but it is in your best interest to try to regulate your bowels and kind of work out those dietary issues before we put an implant in.
Great, thank you. Still have a ton of questions coming in, which we appreciate very much. Can you speak to how the device gets programmed? Is it set to a certain time of the day, or how do you do that?
So I kind of mentioned this during the talk, but the device is programmed to be on at a very low stimulation all the time. So it's not something that gets turned on and off during the day at certain times of the day or using a remote control. It's on all the time to kind of simulate what it would be like to kind of have normal bowel control or bladder control back. So whatever your baseline is as far as your sphincter muscle is kind of the goal that we're going for. It's not going to stop you from having a bowel movement. You'll be able to have a bowel movement normally, but it's not something that needs to be turned on or off during the day.
Great, thank you. This next question is, I've had urinary incontinence for years. I had a sigmoidectomy in December and now have fecal incontinence. Could this device help?
Yes, absolutely. So, one thing that I didn't mention before is a lot of patients have dual incontinence. And, in your particular case, it's hard to say whether your sigmoidectomy kind of resulted in the incontinence because you're having looser bowel movements or because maybe it's some muscle weakness that was always there, but it's just more noticeable now. But with the dual incontinence, a lot of times people are focused on one issue or the other, and then they don't even realize that this device is going to help both problems. So they might come in to see me for fecal incontinence, and then when I do their post-operative appointment, they come in smiling and they're like, Dr. Doss, this helped my bladder too. I didn't even realize it was going to, but now I don't need to get up at night anymore to use the bathroom. And so it definitely works for both fecal and urinary incontinence.
Great. The next question is, could this device also help with levator ani issues?
So that's another indication that's not been researched. And I would say it's something that we'd probably have to talk more about what exactly the issues are that you're experiencing, but it's not one of the current indications for having this device placed.
Great, thank you. This next question, does the condition go away and then the device can be removed?
I would say usually not. And the reason is, the reason we're usually putting the device in is for some irreversible cause of muscle weakness. If you have a reversible cause, like if you have temporary nerve damage that's going to get better at some point, then you really, we wouldn't be putting the device in for that reason. So for most people, I would say it's not something that generally is removed. And one of my one of the things I enjoy about putting this device in is when I do the trial and when patients come in to have the temporary leads removed, most people are very almost upset about it, because they're like, I had such good control for this past week. Are you telling me I have to go a few days without this device now, and until I have the surgery? So it's kind of funny, but yeah, most people aren't going to want to have this removed once they have it put in.
Great, thank you. Just have a couple more questions. The next one being, sorry, the dog's trying to break in. Would this implant help a male with Lewy body dementia and Parkinson's who can get up anywhere between 2 and 12 times per night to urinate?
Yes, it certainly can. So if it is related to urge urinary incontinence, then it certainly can be helpful. Again, we would have to do a full kind of urologic workup to make sure that there aren't any other issues like prostate issues or like stress urinary incontinence that's coming into play. But yes.
Great. The next question is, can the trial period be longer than a week?
Yes, so the longest trial that I have ever done is 2 weeks. I have not done a trial longer than that. So that's pretty much our cutoff for how long a trial can be.
And then a follow-up question to that we have is, during the trial, how do you measure or decide if it works or not?
So that's very much up to the patient. Usually what we do is we send you home with a bowel and bladder diary, and you keep a record of all of your basically bowel habits and urinary habits for that 1 to 2 week period. And then most people will be able to tell whether, their frequency, urgency, and number of accidents that they've had has gone down during that time. And as long as we notice at least a 50% improvement in those numbers, then we are satisfied and we move forward with the implant.
Great, thank you. We touched on this a little bit, but we have a couple people who'd like to know more about insurance coverage, and then also if you're self-pay or private pay, what could that look like for you?
Sure. As far as self-pay costs, I might actually defer that question to you, Natalie, if you know. But I know that, for example, I have had a patient of mine that was from outside of the country, and so they did not have insurance that was going to cover this device, and they did end up paying out of pocket for it. I think the cost of the implant is around $20,000, if I'm not mistaken. Is that correct?
I'm gonna maybe defer to Eric.
Yeah, it really does depend. Sometimes it depends on where we do it. And Matt, if you want to jump in on this.
Yeah, I would just say the facility where you have the implant done really needs to give you that estimate, because there are so many things that go into what they're going to charge you. Anesthesia fees, for instance, beyond just the cost of the device. So the best bet is, if you're a cash pay patient, just to have the facility actually quote you on your out-of-pocket cost.
Yeah, so I mean, the self-pay patients that I have had do this, we usually do at a surgery center to kind of reduce the costs. And that way, both the surgeon fees and the anesthesia fees are kind of the minimum that you would pay, and you're not paying a hospital bill. But that being said, the implant itself, I believe, is on the order of about $20,000 if you're going to pay out of pocket for it. Most insurances, including Medicare and most commercial insurances like Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, all of the big insurance companies do cover this. So that's not a concern for most people.
Great, thank you so much. Next question is, if the person with LBD and Parkinson's also has prostate issues, but is not a candidate for surgery because of total anesthesia, could this implant still be an option?
I would say yes, because we never do this implant under general anesthesia. It's usually more of a sedation. So, if they can't go under some sort of sedation, that might be a limitation. But most people, even people that have had, cardiac issues where they need to get a clearance from their cardiologist to have the procedure done, or very, very elderly people, I've still been able to do this procedure because it's usually done just as a light sedation.
Great, well, thank you. I think that's all of the questions that we had. If you haven't already, please feel free to complete our poll and let us know if you would like to schedule an appointment to see Dr. Doss to go more in depth with your questions, or to get started on a potential treatment plan. Thank you all so much for being here tonight. Thank you so much, Dr. Doss, for your time tonight presenting. Also on your screen, you should still be able to see her phone number. Please jot down the number for Florida Surgical Specialist so that you can call and schedule if you'd prefer. Otherwise, I hope everyone has a great night. Thank you again.
Thank you, everybody.
Bye.
Bye-bye.